Good morning. On behalf of the University of Wisconsin-Madison Global Health Institute, I want to welcome you to the second event. It's part of our four-part series on COVID and equity, what we've learned, where we go from here. And today's webinar topic is Institutions Respond, Ensuring Equitable Care. My name is Jonathan Patz, and I have the good fortune of serving as director of the Global Health Institute here at UW-Madison. For those of you who are new to GHI, we are a unit that works with partners across the university, our state, the nation, and the world to advance global health and well-being for all. GHI works at the intersection of health, equity, and sustainability. Our work is grounded in the global health ethic, a global health ethic that recognizes the health of humans, animals, and the planet's ecosystems that are inextricably linked. We work locally and globally, and our team has been involved in the COVID response from the frontline care to policy advice and strategic planning. We developed this COVID and equity webinar series in response to the significant health disparities illuminated by this pandemic. And we have additional funding from the EVU Foundation for this seminar series that I'd like to thank EVU for this. The challenges of equity and systemic racism have been further magnified to protests over the death of George Floyd and others from police brutality, igniting a movement for justice locally and around the world. GHI has brought together a diverse group of campus, community, and international voices to examine the lessons we've learned from the pandemic and to translate lessons learned into actionable next steps to begin to move forward. Today, we welcome four incredible voices of leaders from institutions responding to the COVID-19 pandemic. They'll discuss policies that have guided the COVID response and their impact. They will consider whether or not health is a human right and who will ensure that health care is available to all. They'll also discuss how to best collaborate with communities adversely impacted by equities and how timely in this week when moratoriums both on evictions and electricity cutoffs are ending in the midst of a nationwide heat wave. Before we get started, I'd like to remind everyone that this session is being recorded, and there's a link to the archive video along with an event summary that will be available on our GHI website. Your microphones were muted when you joined the webinar, so key to remember, if you have questions for our panelists, please use the chat box. I'd like to also thank everyone who helped organize this event, as well as our moderator and panelists for being here. So without further ado, I'd like to introduce our moderator, Ambassador John Lange, Senior Fellow for Global Health Diplomacy at the UN Foundation and a member of GHI's Board of Visitors. John worked from 2009 to 2013 at the Bill and Melinda Gates Foundation. During his 28-year career in the Foreign Service at the U.S. Department of State, he was a pioneer in the field of global health diplomacy. He served as special representative on avian and pandemic influenza, Deputy Inspector General, Deputy U.S. Global AIDS Coordinator at the incept of the President's Emergency Plan for AIDS Relief, or PEPFAR, as many of us know. He was the U.S. Ambassador to Botswana, and he led the U.S. Embassy in Dar es Salaam, Tanzania, as Change d'Affaires during the August 7th, 1998 terrorist bombing. John, thank you so much for your leadership and your dedication to global health and for agreeing to be our moderator today. So over to you, John. Thank you.
Thank you very much, Jonathan, for the invitation to serve as the moderator. with our distinguished group of panelists today. And congratulations to you and the Global Health Institute for this important series on COVID and equity. I am invited to probably 2 webinars a day on different issues related to COVID-19, and I don't recall any of them talking about as the main theme equity, and I really congratulate you for that. Today, unlike last week's webinar, which was more of a domestic focus, we're going to be focusing on key issues related to the international response and how international institutions are responding to the global COVID-19 pandemic. For all of us, time is a bit different these days in the midst of social distancing and lockdowns, but it seems to be a long time ago, but it was only January 30th when the Director General of the World Health Organization, WHO, declared the novel coronavirus, COVID-19, to be a public health emergency of international concern. That's an official phrase in the international health regulations, and it triggered specific notification and reporting requirements from all countries who have signed the international health regulations. But at that time, it was quite noticeable. Dr. Tedros said, and I'll quote here, "Our greatest concern is the potential for the virus to spread to countries with weaker health systems and which are ill-equipped to deal with it. The only way we will defeat this outbreak is for all countries to work together in a spirit of solidarity and cooperation." And he's continued emphasizing the need to assist countries with weaker health systems and people who are marginalized. Or just earlier this week, on Monday, he expressed concern about the impact of the COVID-19 pandemic on indigenous populations, particularly in the Americas, the current epicenter of the pandemic. He was specifically concerned about COVID-19 cases among Peru's Amazonian Nahuatl people. And it's been that way with other international institutions. The UN Secretary General Antonio Guterres has emphasized that we all need to build back better from the current crisis. As the world begins planning for a post-pandemic recovery, it is crucial to seize the opportunity to build back better by creating more sustainable, resilient, and inclusive societies. On July 17th, the Secretary General said, "This crisis risks halting and reversing progress on poverty eradication, food security, gender equality, and other sustainable development goals. The pandemic has exposed and exacerbated vulnerabilities and inequalities within and among countries." And then you can look at the World Bank Group. And today we have a panelist from the World Bank Group, Graham. They've responded with the largest and fastest crisis response in their history. Emergency operations have now reached more than 100 countries, home to over 70% of the world's population. And these operations are financing health and social programs with a special focus on the poorest and most vulnerable people. As Mohammed Ali Pateh, the World Bank's Global Director of Health, Nutrition, and Program and Populations, explained, "Our goal is not only to save lives, but to help countries build stronger, more resilient health systems, to be better prepared for future disease outbreaks, and ensure no one is left behind." And we'll be hearing from Lori DiPrete Brown later about some of the human rights issues. And the UN's Office of the High Commissioner for Human Rights has issued guidance for COVID-19, emphasizing that respect for human rights across the spectrum of human rights, including economic, social, cultural, civil, and political rights, will be fundamental to the success of the public health response and recovery from the pandemic. And to give another example of this constant emphasis on the part of international organizations to deal with this COVID-19 crisis by trying to help the poorest and most vulnerable, on July 27th in the Lancet, a prominent health publication, the heads of UNICEF, the Food and Agriculture Organization, the World Food Program, and WHO wrote about their fear of malnutrition, and especially in low and middle income countries, and especially among young children. And this malnutrition is a concern because COVID-19 strategies, such as social distancing and lockdowns, have actually turned out to be disruptive to food production and transportation and sale. The health systems all around the world are strained. Humanitarian responses in the countries in the midst of conflict where their humanitarian needs have been disrupted. And social protection systems, such as food banks, etc., are overloaded. So there now is a great concern about malnutrition, and this has been emphasized by the heads of those 4 agencies, as I said. I would like to give a plug for a way that you can be helpful. The UN Foundation, where I'm employed, and the Swift's Philanthropy Foundation together are hosting what is called the COVID-19 Solidarity Response Fund. That's at covid19responsefund.org. And the idea is it's a way for individuals to support the work of these international organizations. The money goes to WHO, or at WHO's request goes to other agencies, and it's gone to several of the international organizations I already mentioned. And so far, it's received more than $231 million in commitments. So if you want to help, it's covid19responsefund.org. So that gives you just a broad sense before we get into the more details by the real experts on this of how the international institutions are responding to COVID-19 and that theme of equity in the Global Health Institute's webinar series. It's a huge topic, but we've got some real experts on this. Our first speaker will be Stewart Simonson. He's Assistant Director General at the World Health Organization's office at the UN in New York. He has a wealth of relevant experience, and that includes being at the U.S. Department of Health and Human Services as the Assistant Secretary for Public Health Emergency Preparedness back in the days when someone well known in Wisconsin, Tommy Thompson, was the Secretary of Health and Human Services, and the world was preparing for a possible H5N1 pandemic influenza. He's also a Wisconsin Badger who earned his law degree from UW-Madison. Graham Harrison is a senior science and technology consultant at the World Bank, where he works primarily on higher education projects, including the Africa Centers of Excellence Impact Project. From 2009 to 2018, he served as a program officer in the Office of International Science and Engineering at the U.S. National Science Foundation. He earned his PhD in chemical engineering from the University of California at Santa Barbara. And Lori DiPrete Brown is an associate director at the UW-Madison Global Health Institute and founding director of 4W, Women and Wellbeing in Wisconsin and the World initiative. She focuses her scholarship on global health, particularly the health and well-being of women and children in highly vulnerable situations around the world. And she holds degrees from Yale College, the Harvard School of Public Health, and the Harvard Divinity School. So now let me turn it over to Stewart to hear from the perspective from WHO. Please.
Thank you, John. I'm grateful to have been included in this session at my alma mater. I'm also an undergrad alum of Madison. I was recouping my parents' property taxes, so I did the whole, all of it there. So let me talk just a little about where we are today with COVID-19, about 8 months into this pandemic. We have about 17 million cases reported globally, adding about between 200 and 300,000 cases a day, and mortality at about 700,000 globally. So this is the real deal. This is not something that is a flash in the pan. It's not like SARS. It's not just going to go away. It is here to stay. And we have to learn to live with it and to respond to it. Absent a vaccine and other countermeasures, we will not exit this pandemic. So WHO has a number of initiatives directed at responding to COVID-19. For some 150 countries, we are really the principal resource outside of the country. And in the U.S. and in the developed world, there are institutions like CDC and NIH, but in much of the world that isn't the case, and we serve that function. We provide the guidance and the assistance that those countries need to respond. So WHO has been providing from the very beginning laboratory tests, reagents, and other laboratory supplies to countries around the world. We have been focused very aggressively on other supply chain issues and in moving personal protective equipment, masks, gloves, so forth, face shields, to places where it is needed most. And we continue to do that. We have literally moved hundreds of tons of material around the world to help countries respond. And we are working through the ACT Accelerator on vaccines and countermeasures, with a particular focus on equity. As Dr. Tedros has said, and John alluded to it in his remarks, our concerns are focused on countries without health systems, countries with weak health systems, because they have no other resources other than WHO. And so we have been spending a fair amount of our effort, a lot of our effort, to support those countries. And that will include providing them with vaccines and therapeutics. The bottom line with this disease, or really with any virus, go back and look at the 1918, none of us are safe until all of us are safe. So it isn't altruism to look to countries without health systems and to help them and to assist them in responding. It is self-interest. And I think really, if anything is clear now to all of us, it is that health is more than a human right. It is a human right. This was a basic human right. This was, I think, articulated very clearly in WHO's Constitution in 1948. But it is also a national security necessity. Look at the impact of COVID-19. Not since World War II have we seen this level of disruption. Look at the impact on economies. Trillions of dollars will have been lost because of COVID-19. So it is a national security imperative to build health systems and public health response networks around the world. There has been, and I can say from my experience, both working for the state of Wisconsin and for HHS, there has been a lot of talk about biodefense and bioterrorism. There is no bioterror threat as serious, human bioterror threat, as nature. Nature is the biggest and the most really formidable threat. And we should be developing systems and infrastructure to deal with nature, not just the man-made threats, whether on the conventional warfare side or on in terms of biodefense. We have to treat health as a national security imperative. Before coming to WHO, I spent about 5 years in Haiti, 4.5 years in Haiti, as an administrator at a hospital in the north. And Haiti doesn't have health systems. Right now, they're reporting a health system to speak of, at least. Right now, they're reporting about 7,500 cases of COVID-19. Their neighbor, the Dominican Republic, which has a health system, and about the same population, is reporting about 75,000 cases. So we're not seeing in some places COVID exploding as we know it is, because there isn't the testing or the infrastructure to confirm cases or to give us an accurate picture of what is happening on the ground. And so in places like Haiti, WHO, through the Pan American Health Organization, spending a lot of time to help the Ministry of Health and the networks of hospitals that are there. There are Catholic hospitals and Baptist and Adventist hospitals, so forth, to prepare and respond, moving personal protective equipment, laboratory supplies, oxygen generators, which in the U.S. every hospital has. In Haiti, there are regions of the country where there are no oxygen generators. They have to have it brought in. Because of COVID-19, we will have oxygen generators in every department of the country, and probably more than one oxygen generator. So there are some, I think, important steps being taken to address the acute health system failure or deficit in places like Haiti. But there will need to be a heck of a lot more done. I think really what we should take away from COVID-19 is that the SDGs, and in particular SDG 3, is not just a luxury or not an expression of altruism. It is essential, and we should fund it accordingly. I mean, without, as I said, without a vaccine or another countermeasure that can be made available globally, we will not exit this. It will burn itself out eventually, as the 1918 did. But with a vaccine, with countermeasures, with traditional or non-pharmaceutical public health interventions, we can manage this and we can exit. But only if we make these countermeasures available to everyone. And there isn't the infrastructure for that now, really, in the U.S. or around the world. But investments are being made today that I think will yield some real benefit, not just in the COVID response, but generally in terms of achieving universal health care, SDG 3. Let me just close by saying something that is maybe a little more optimistic, a little more positive. The Middle Ages closed with the end of the Black Death, the biggest pandemic that the world had seen to that point. And what began after was the Renaissance. The 1918 died out in 1920, 1921, and what came after? The Roaring 20s. There is, I think, every likelihood that COVID will be followed by a similar period of growth and imagination and improvement in society. And as the Secretary General says, this is an opportunity for us to rebuild better. I hope that health systems will be the first thing that is addressed in this positive growth period following COVID-19. And indeed, I hope it will be addressed during COVID-19, because without it, we are all at risk. As I said, it is a basic human right, healthcare, but it is also a national security imperative, and we need to invest in it accordingly. Thank you, John.
Thank you very much, Stewart. It's a cliche heard often in the global health world, but a threat anywhere is a threat everywhere, and you've really made a strong case for strengthening health systems. We'd now like to get the perspective from the World Bank, so if I could turn it over to Graham Harrison. Please, go ahead, Graham.
Well, thank you very much, John. And I think I have some slides coming up, but I don't think you can see them yet. Let me get started. My name is Graham Harrison. I actually work in the education global practice at the World Bank. I'd like to talk a little bit about the Africa Centers of Excellence projects, which are higher education projects, but also make some remarks in terms of how that leads into health and how that leads into addressing the COVID crisis. Next slide, please. So the ACE projects are really designed to support excellence in postgraduate education across research. These centers of excellence are competitively selected using international standards. They're supported by international experts, including some from University of Wisconsin. And really the goal is to train master's and PhD students in Africa to address the skills gap and also to address the issues particularly relevant to Africa. One of our goals is to have 30% of the students being female at the postgraduate level, and that's across all science and engineering and health, agriculture disciplines. That's an ambitious goal, but it's something that we really believe in strongly. It's essential to equity, and it's essential to getting the entire workforce involved in addressing all challenges faced by the continent. And the research is definitely driven by what are the health issues or the issues of whatever topic in the African context. So we're looking at development challenges. You could also look at the SDGs, as was just said, in terms of that, and also looking at the impact in which we're making in addressing those SDGs in a practical and tangible way. A key element, and I think this is also consistent with what was previously said, and also with the SDGs, is this is a regional rather than a national focus. These are not national issues. COVID is not a national issue. It has to be done in a coordinated fashion across the globe, and also leveraging the capacity that does exist in one country to work more broadly across the region and across the globe. We look at institutional impact within the universities. So looking at poles of excellence that may exist in research, but how can that strengthen the overall capacity of the institution to deliver its academic mission that strengthens the ability of the country to respond as well. These are government-owned projects. What does that mean in terms of higher education? That means these are nationally selected to be reflective of what the government's priorities are, but also it's done in conjunction with the other governments in the region as well. So again, the coordinated approach to address big issues. It's results-based financing. So a university sees this as a grant. So much like those of you who work at Wisconsin Research Environment, you get a grant. On the other hand, to spend the money, you actually have to earn the money first. So we have particular targets that have to be reached. Once you've reached those targets, money is released for you to then spend on your research and other academic endeavors. And these are large projects. If you look at since 2014, this is going into higher education and applied research in Africa. It's $700 million for postgraduate research and training. That's one of the largest investments you'll see in Africa from anywhere in the world. It's actually focused on this particular level, and it reflects the importance that higher education, advanced studies, and students, and the impact that these graduates are expected to make in the countries as well. Remember, these are not grants to the countries. World Bank programs are typically concessionary loans that go to the government. They do have to be repaid back over an extended period of time. So these are an investment that the governments are making in these particular projects. Next slide, please. So this is just a map in terms of where the ACE projects are working. So we're focused primarily in the two projects ongoing right now. ACE Impact is in West and Central Africa with about 45 centers of excellence. And then on the east and southern side, we have another 24 centers, and they go across all disciplines, STEM, agriculture, and health as well. We have 20 countries, Anglophone countries, Francophone countries, Lusophone countries. Again, the issues that we're talking about cross countries, they cross language groups as well. The countries also have to choose to participate in these projects. So out of the 50-odd countries in Africa, we have 20 participating. We don't work with North Africa because that's typically another region within the World Bank. Next slide, please. So as I said, we have 70 centers of excellence. 20% of those focus on health in a general sense, whether it be public health, Infectious disease, non-communicable diseases, bioinformatics are some of the main areas in which we have centers that are operating. They get typically between $6 and $8 million from the World Bank over 5 years. That's a considerable amount of money in Africa. In particular, that can go to build a building, which may cost a couple of $1 million in Africa, which is probably a better deal than you're getting on the campus in Madison for a new building. These centers also have external funding. So we are looking at globally competitive, globally relevant researchers. So they're getting NIH funding, Wellcome Trust, DAD from the Germans as some examples. Next slide, please. So in terms of COVID, this is a key element in terms of how these centers are responding to this. Obviously, the universities have physically closed in large part their campus. Another thing is, though, however, these ACE centers do provide on-the-ground capacity, not just for training, not just for research, but also for public health interests as well. And they do come with this funding from the World Bank ACE project. So the research of all of our centers, health or otherwise, frankly, much like research in many countries, has pivoted to responding to the pandemic. So for example, some of our centers have been working on genome sequencing, mass testing in country, providing the testing and the results, modeling the spread of the pandemic, training healthcare workers, and even the STEM centers are working on PPE and sanitizer using some of their equipment and their experimental resources as well. And remember, these are all being done nationally, and they're definitely being taken advantage of by the national government, but they're acting also within the regional capacity of the project as well. Next slide, please. I also want to address briefly the concept of equity, which is one of the themes of this series, and especially the issue of equity in education, and in some ways how this is responding, or how this is being brought to the forefront in the COVID pandemic in the African context. We've talked a lot about equity around the US in terms of K through 12, and also, frankly, in terms of higher education, in terms of resources of universities and schools to deliver learning and teaching to their students. That's the more extreme example, of course, in Africa. So the question, of course, becomes how to maintain and or relaunch university teaching in this environment. I'll focus on higher education. Institutional bandwidth, the internet capacity of the university is a real issue in Africa. Wi-Fi is typically not available around campus. The bandwidth going to a university may be approaching what you have in a house in Wisconsin. Learning management systems are not fully utilized in Africa. Some of them are rudimentary in some sense. The faculty bandwidth teaching from home using a Zoom, if you don't have internet at home, it's very difficult to use that as a facility. Student connectivity is an absolutely huge issue, and this really goes to address the issue of equity as well. Access, what sort of devices do they have? What the speed of those devices, the reliability of your internet signal. One of the things we find out is that when we have a webinar with Africa, the number of people who lose connectivity during the course of a 1-hour webinar. And also the cost of connectivity, whether it be for students or institutions as well. Orders of magnitude sometimes higher than in the US. Mobile phones are the primary way in which students connect. Home internet is doubtful to begin with. I think it's 1/3 in some countries that we see in terms of home internet. For university students, let alone the rest of the population. Wi-Fi at home is very rare, and whereas we may all have a cell phone, an iPad, and several computers at home, the lack of devices also affects the ability to learn and receive content over a connection. So it's really an issue that we have to address, and this is one of the ways in which the World Bank is responding here, but it also goes beyond the COVID crisis, and I think it lines up with what was previously said, building long-term resilience, not just in the health sector, but also in the higher education sector that then feeds into the staff who's coming into the health sector as well. And just the last slide, please, I think. I want to just touch on a little bit more broadly the World Bank response to COVID-19. The priority, of course, is fast action. And I think what's important to note here is that some projects have been approved in days and weeks rather than the typical months and or years of preparation to go here. Priorities are pandemic response, increased surveillance, alluding to what was said about Haiti versus Dominican Republic previously, improve public health interventions, and then in alignment with the World Bank twin goals, which are both ending extreme poverty and boosting shared prosperity, making sure we're looking at social protection and also sustaining jobs in those countries so that when the pandemic eases, then the economy can come back to life as well. That's an important element. A couple of numbers. On April 2nd, so we know that in terms of the context, for example, of when the US started shutting down in mid-March, so 2.5 weeks later, an initial $1.9 billion of new funding went out the door to 25 countries. That's an extremely fast turnaround from the World Bank project preparation perspective. By May 19th, 2 months really after the US had shut down, just as a reference point. Emergency operations in 100 countries were supported by that point, and those, as was mentioned, cover 70% of the world's population in terms of where those activities happen. It's not just new projects that are being done, although there's a lot of new financing that's available and new projects that have been launched. There's also been redeployment of existing projects, not just in health, but also in higher education and all the other GPs to see how we can redeploy project funds to respond to the ongoing crisis at this particular time. So with that, I'll stop and thank you very much for your time. Thank you.
Thank you very much, Graham. It's quite impressive how the World Bank as a whole has responded so quickly, but also quite depressing to think of all the disruptions in the universities that you're working on in the Africa Centers for Excellence. So it's not just the University of Wisconsin-Madison that has been disrupted through this COVID-19. All right, now we'd like to hear from someone who's at the university in Madison, who's works in the Global Health Institute, Lori DiPrete Brown. Please, Lori, go ahead. Can't hear you, Lori.
Thanks so much, John. I really appreciate the comments of the previous speakers. These are institutions that have been focusing on, global change before COVID. And so in many ways, a lot of institutions in our global health sector have been facing in the right direction already. And so what I want to look at is, what more can we be doing? And I think the questions are not, are we doing something, but, how can we do as much as we can? And when we think about equity and inclusion in our institutions, are people present? That's question one. Do they feel they belong, and are they feeling that they're contributing maximally is question two. These are not questions I'm posing to the other panelists. These are the questions I'm trying to pose every day to myself in my own work, because I think we all have to work toward institutional equity as we change the world, change ourselves as institutions. And we live in a moment when institutions, civic society, governance are probably our best hopes, and yet our major institutions have let us down in different ways. So it's a time of hope, and it's a time for persistence and care. So with that, I'd like to go to the first slide. Oh, first slide. Sorry, can you back up, please? Yeah. So I've entitled this, How Do We Get There? Because we do hear a lot of consensus already on where we want to be. And how you get there, there are many roads, and it's expressions of solidarity and policy are a critical first step. And then the implementation of that is very tricky. It can take 20 years for, a state-of-the-art medical intervention that's not even contested to get into practice. So what about, in an era of complexity? And so I'm going to talk a little bit about how some of the guidance that we have from human rights, from SDGs, and from system strengthening principles can help us. Next, please. I'd like to put the COVID-19 mortality in context. Last night, about 665,000 deaths. You can see the other global causes of death. HIV/AIDS in 2019, 690. Putting that in perspective, at the peak, HIV/AIDS was 2 million a year. So, this is HIV/AIDS has become more of a chronic disease, still working on stopping infection, but you can look at the comparison there. You can see that we've surpassed malaria. The influenza deaths, very contested, but recent estimates are, 389,000 with a very large confidence interval. And then you have under 5 malnutrition-related deaths, which are 3.1 million per year. So there are equity issues within and around COVID, and we're beginning to think about, not falling into the dangers of inadvertently doing harm by having too much of a vertical focus. I think you heard a great counterexample in the example of oxygen. The whole world may have access to oxygen because of COVID, and it helps with a lot of things, but people are missing vaccinations and so forth. So we need to pay close attention to these things. I think when you think about COVID and equity, COVID is mainly magnifying inequities that were already there because of differences in our resources, differences in our health status, differences in the number of choices we have, differences in the nature of our work. So I see it as COVID has opened a wound, an infected wound, and while that's a painful moment, it's hard to look at it. Let's name it for what it is and clean it and let it heal properly. It's time to do that, and we can, I think, do that. Next, please. So how can I ask myself, how can I set a higher bar for myself and my global health institution? I represent, public higher ed, which I think is one of the greatest hopes that we have now, and, we need to do more. And I think there are these three principles that all can address excellence and equity and effectiveness. Human rights is a foundational element, health system strengthening, and the SDGs. Next, please. In terms of human rights, I want to just get into a little bit of the nitty-gritty details of human rights because I'm a QI practitioner, implementation science, research to practice is my thing. I like doing stuff. And the 1945 is the first mention of health. In 1966, with the Article 12 of the Convention on Economic and Social Rights, you get specific reference to epidemic control being important. And then in 2000, when we really tried to say, what does this right to highest attainable health mean? Part of that, and vaccination and epidemic and prevention of epidemics are specifically named as priorities. Non-discrimination is specifically named as a priority. Black lives have mattered in this space for a long time. We who are of a certain age lived through, Blacks achieving freedom in South Africa. And we need to be sticking to this conversation and having explicit conversations. Rights-based approaches, besides doing the right thing, they ask us to be explicit about that it is rights-based, that it includes participation and local ownership. I think when Stewart spoke, he did that. He didn't just talk about national security, which is paramount and key to building the consensus we need, but the rights-based mention was there too. And I think we don't want to uncouple these rationales. The most power is when we bring the different rationales together to get a broad consensus. So back to the details of Article 12, or General Comment 14 in the year 2000, the elements of the right to health were defined as 3 A's and a Q: availability, accessibility, acceptability, and quality. And this brings you into a beautiful place where you can draw links between health system strengthening, a lot of the very ordinary, box checker stuff that keeps people safe at the point of care. You're realizing human rights of people when you do that careful care. And so I'm going to really be pointing to health system strengthening as a big source of hope here, and possibly a slightly underutilized one in this moment. Next, please. So we have some guidance beginning to have conversations about what might be important for human rights and COVID, and some do's and don'ts. Some are obvious, but you need to, crazy things happen in an emergency by the best of us. So make sure you don't discriminate in what you're doing. Find multiple ways to look at that question. Make sure you're centering the needs of marginalized groups, planning that from the beginning. Because if you don't design it with that in mind, it might be harder to adapt to get to everyone. Avoid using excessive force or surveillance that's unnecessary. This is the right amount, the minimal amount. Human rights and public health have always had this tension between individual rights and the public safety. And we need to honor both of that special balance to keep our credibility in the public square as medical public health leaders. People have a right to full access information, not just patients, but journalists and people, everybody, even if they're whatever institution they're in, they need to feel free to speak. This is vital to our dialogue. Water and sanitation are vital for this healthcare. So we're getting back to the basics. You can think of ORT and how we created salts that save lives, and fixing the water systems was also important. Now we need those water systems to keep our hands clean for COVID. The gender focus is essential. I'll talk about that more in a bit. And then the privacy rights and also the rights of human subjects need to get a lot of attention here. So this is some guidance. This is from Amnesty International. They're not things you wouldn't think of, but they're things that need to be a constant sort of checklist in your mind so you avoid that well-intentioned inadvertent harm. Next, please. Going now to systems thinking. COVID-19 is a really wicked, complex problem. And we know that we're going to have a lot more of them in the modern era. Most of the human population, probably 5 of our 7 billion, live in worlds that are complex and wicked, and things are upside down, and it's hard to plan, it's hard to be sure of things. So now everybody's in that place. We're kind of, welcome to the human condition in a way. So learning to be resilient when you know that complex systems will have collapses here and there, that's a given. It is not the case that you can create complete safety. What you can create is social solidarity for rapid resilience so that you minimize the harm. And this wicked problem map here, you can take some time to look at it another time, it just shows how health and water and food and the economy are all interconnected. So simple problems have simple solutions, guidelines, checklists, protocols, rigidity, it works, it gives you consistency. Complicated problems have best practices and good practices that can work. But when you get into complex or chaotic situations, by chaotic, we mean that we don't know what to do. We don't have full information. We don't totally understand causality. We don't know what's going to happen. That's where emergent practice and novel practice comes in, and a different kind of organizational ethos is needed and a different kind of leadership. And it really needs to be value-based. So what some will say simply, and this is the trite but true, summary, is that you really need to have a few simple rules and values, that clarity of purpose, real clear purpose when a lot of people have choices to make, and then a few simple rules is the best way to get through this, because information is going to change, and showing the public that you understand that and you're going to change with it and be responsive, you're building a social solidarity to make a system move. So complex systems are just very beautiful. When you think of a flock of birds taking flight all at once, these things are just magical, and they're not what vaccine PPE protocols are different. That fits in the simple model. So when you have something like COVID, we have simple, complicated, and complex problems all happening at once, and that's at an interscalar level as well, with local governments, state, national, and international. So how those different layers and lenses come together, it's systems thinking, and we need to be, creating a generation of problem solvers in our students that have that agility of thought. It's not standing in the water anymore. We have to be able to surf. Next, please. And so this is a really great story, and you can watch it quickly on this video with Anthony Staines. And he is, what he's saying here is that when the COVID broke out, quality improvement professionals were asked to stay home because there wasn't time, or to put on, if they were clinicians, come into direct service. People forgot that they had the very tools that might help the system adapt quickly with guidelines and so forth. And so particularly things like new guidelines and protocols, looking at strengthening equity in the organization, and being careful to avoid one-size-fits-all solutions that can create harm is something that we all need to think about. Next, please. So I also want to talk a bit about the SDGs and the nature of this. So I think about the SDGs. The SDGs are useful as a set of indicators, a set of buckets for categorizing our work. However, we also can think about this as a lens or a framework to address complexity. And it can be something where citizens can participate and have this way of looking at things that gives us a framework for the social solidarity we'll need to kind of be we the people as we make decisions. Local governments have frameworks for using the SDGs, and it creates opportunities to share solutions, voluntary local reporting. Again, this helps make change more quickly. So I think the SDGs really are a North Star to guide us in these complex times. They bring in the equity, they bring in the national security and the peace building, they bring in the health system strengthening, food systems, water systems, and the environment and climate change, and the kinds of ways that we need to be prepared to make change in that regard. Next, please. I think higher education can be a really important partner here, and higher education as an institution can, should, and must reform. Oh, we're missing one slide. Okay. Well, I want to talk a little bit about gender equity, because there was a slide on gender equity that's not here, but I want to say two things about that. One is we have two groups I encourage you to listen to. One is the Dear Pandemic group, and that is the Nerdy Girls, who are a group of women epidemiologists who are building a lot of trust and being listened to. And the other is the Women in Global Health group, who are really looking at how can we have 50-50 solutions in global health. And finally, I just want to say in terms of higher education, I think we need to be a partner. We need to foster resilience and partner with the private sector, with governance, with civil society. And we need to be linking learning, research, practice, and citizenship as much as we do and more than ever. I think the world is really becoming a neighborhood, and we can make it an inclusive and a one. And I would close by saying, build back better, but don't just build back better. Build back just as well.
Thank you very much, Lori, for that perspective. And I really like the idea of the Sustainable Development Goals as a North Star in terms of how we build back better and build back just, as you point out. Just a reminder to everybody, if you'd like to submit a question, please do it through the chat function. I would have to say that I'm very concerned about one fundamental issue in equity, and that is the prioritization of a vaccine once it becomes available. And I'd really like to hear from our three speakers your perspectives on how the institutions that you represent, whether it's the WHO or the World Bank or higher education, how you see this playing out, and if there's any role that your institution has in it to play in it. There is something that Stewart Simonson alluded to earlier, the Access to COVID-19 Tools Accelerator, called ACT. It's a new groundbreaking collaborative effort to accelerate development, production, and equitable access to COVID-19 tests, treatments, vaccines. It was launched at the end of April. It brings together governments, scientists, businesses, civil society, philanthropists, and global health organizations, including the World Bank and WHO and the Bill and Melinda Gates Foundation and the Global Fund to fight AIDS, TB, and malaria, and others. And they want to support the development and equitable distribution of the tests, treatments, and vaccines the world needs. But when I was the special representative on avian and pandemic influenza at the State Department, we spent 2 years in my office, and it went on for 2 more years after I retired. So a total of 4 years negotiating vaccine benefit sharing and virus sharing. In other words, the idea, if you have and then the fear was from the H5N1 virus spreading in Indonesia, if it became a human-to-human transmission and an influenza pandemic, you want to exchange those viruses with CDC and other laboratories as quickly as possible. But Indonesia didn't want to share the virus if then when the vaccine produced from that virus was given first in the developed world, in the United States and elsewhere, and last on the list would be the developing countries. So this went on for 4 years of negotiations because of the fear on the part of many developing countries that they'd be last on the list to get a vaccine. This act and other efforts are different, but won't individual countries be disrupting this theory of global equity? Do you really think that heads of state are going to be saying, oh, well, yes, let's give it to the frontline health workers in Malawi before giving it to the frontline health workers and the citizens of my country, if these heads of state are from the global north. I'm just very fearful that the biggest equity issue in COVID-19 will come about when this vaccine is finally ready in limited quantities. So why don't we go in the same order that we had the speakers? Stewart, do you have any thoughts on that?
Well, I mean, there's no doubt about it that this is a concern and where the vaccine will be made available. My own view is that the decisions there should be informed by the dynamics of the pandemic, and to get ahead of the pandemic and to slow it down, it may make sense to direct the vaccine to places where it is hot, most hot, and to use the vaccine as a tool to slow down the spread and to allow the vaccine production infrastructure to catch up and to be able to provide it to everyone. The fact is, if we leave pockets of the world unvaccinated, we will, I think, live to regret it. And so, or maybe not live to regret it. And so I think we really have to focus on the dynamics of the pandemic in at least the initial decisions concerning vaccine distribution.
Thank you. Graham?
So I don't want to address the issues in terms of what the bank's official view on that is, because I don't know. I'm in the education sector side of things. I will point out in terms of IP generated in research and also in terms of equity, in terms of the system. I think what's important, let me talk from an education point of view, building up capacity in lots of different countries in terms of public health systems, but also in terms of the research that's ongoing, is an important element in fighting any pandemic or any indication. I'll go back to the Ebola crisis. For example, there's a lot of testing being done in Europe for Africa. And one of our centers developed the testing capacity in Africa to develop the testing locally as well. That's one thing where centers of excellence, where there is excellent research by globally competitive standards, can contribute to these efforts. And in alignment with what was said earlier, the former NSF director who I worked for said, good science anywhere is good for science everywhere. And I think that's the same sort of thing that goes on with these sorts of ideas here. IP is a very strong issue, and is a great fear in much of the developing world in terms of when IP is generated in Africa or in parts of Asia or in Latin America, that is going to be taken by those in richer, more powerful research countries. That's an ongoing concern in these countries. Whether it's true is a mixed bag, I think.
Thank you. Lori?
Yeah, I just have a very brief comment here, just as a point of light out there. Thinking about the meningitis vaccine and what happened in the collaborations with Africa. I mean, I believe that 99% of the population from 1 to 29 was vaccinated within 8 days in Burkina Faso. So we have examples of really good collaboration, and if we can get in the spirit and learn from that experience, we can do this as a global community. I just think part of it is believing each other and building the trust. It happens on a soccer team, it happens at a university, it happens among global presidents. So it's, I feel hopeful in spite of all.
John, I should have added that this question of equity is embedded in everything we think about at WHO. So it is very important to us as a consideration, a very important consideration. I have not been part of the decision-making for this, but as I said, it just seems to me that the dynamics of the outbreak or of the pandemic have to inform decisions about where a vaccine is made available. But if it's like influenza or other vaccines where it's only in the developed world, I think that is a solution to nothing. And so we have to strive for that. And I think that's part of building back better, is creating an infrastructure to enable us to respond to emerging threats. COVID-19 won't be the last. Nature's a tough customer and has a lot of other viruses that can wreak even more havoc than COVID-19, and we've got to be ready to respond to them too. This is not going to be an event that then turns the page on pandemic threats. It is maybe just the beginning for us of a realization of how serious this threat is.
Thank you for that comment, Stewart, and Lori for the earlier discussion. We've run out of time, so we're not going to be able to take more questions. I would have to mention that one person in the chat said, hopefully we'll have a smarter, more environmentally friendly economy after COVID. And I think there are a lot of negatives that we've talked about, a lot of concerns in the issues of equity. But to me, I find this conversation to be quite uplifting, because there are so many efforts going on to deal with those concerns. It's a great challenge, as anybody who's lived in the developing world knows, to try to bring equitable solutions. But the effort is being made by many international institutions, by including foundations such as the Bill and Melinda Gates Foundation. You have plans for the future that include the North Star, as Lori said, the Sustainable Development Goals, and what I think is really a superb work and responses being implemented by the World Health Organization and the World Bank. And there's just a lot of reasons for hope in the midst of this catastrophic pandemic. So thank you for your time and your wisdom and willingness to engage on this to all three panelists. As you heard earlier from Jonathan Patz, this session has been recorded. It'll be available on the Global Health Institute's website. We hope that today's discussion will serve to inform policymakers, program managers, researchers, and others as they plan next steps for more lessons, to learn from the lessons that we talked about today, and hopefully that will lay the groundwork for actionable next steps to ensure equity in the response to COVID-19. And lastly, thanks to the participants. We had well over 100 participants joining us today. This is the second in a 4-part webinar series that continues on August 20th and August 27th, and you'll find all that information on GHI's website, ghi.wisc.edu. So thank you again, participants. I think you did a great job. We really appreciate your time, and thank you all for attending. Have a good day, everyone.